So without further ado, we'll get started because we have lots to cover. We're very pleased to be having this discussion on, I think it's the second annual European Hormone Day. So where there is a focus from patient organisations and professional bodies to raise awareness of the role that hormones play in our health and in our life. And without further ado, I'm so delighted and honoured to be welcoming Professor Helen Mason, Verity's long-term scientific advisor who we love and adore dearly, and you will see why as we go through this discussion. Thank you, Professor Mason, for making time for us today. And I'll pass to you firstly if you'd like to introduce yourself.
So, welcome to everybody. Thank you for hopping on without a lot of notice because Rachel and I are not the best communicators, but anyway, we got there in the end. I really just want to have a shout out for the women who run Verity, who I think are utterly remarkable and have really helped to raise the profile of PCO. Selfless, constant hard work. And I admire them all absolutely enormously.
Thank you very much.
And I love PCO. I don't actually know if I got it or not because there's a few queries about it, but for me, it's kept me in my beautiful career for a lifetime. So I'm grateful to all of you out there for having it. And I do actually utterly understand why it's not a great syndrome to have. And we'll go through some of why that is. We're going to stop intermittently so we can tackle some of the questions and so I can get my breath back a bit. So please feel free to pop things onto the website as they come into your mind. And also we've got one or two questions that came in advance that we'll try and tackle. So I think the first place to start is by saying actually what polycystic ovaries are, and maybe more importantly, what they're not. I hear over and over, women have been told, you've got cysts all over your ovaries. No, you don't. First of all, you don't have anything all over your ovaries. And for most of you, you don't actually have any cysts. So polycystic ovaries were just really badly named right from the beginning. And it's kind of got a bit late to try and change that, although there is a move afoot to try and change the name of it. So what is a polycystic ovary? Well, if we think first of all about normal ovaries, and with polycystic ovaries, when you're born, you've got about 500,000 eggs sitting in the outside layer of the ovary. After puberty, some of these start to grow, and eventually they will get into a menstrual cycle. As the hormones change in the menstrual cycle, they pick up one or two of these, and the little tiny eggs that are sitting inside these fluid-filled sacs will grow, and the egg will be released, and the cycle will then start again. So each of these eggs is surrounded by cells, two layers of cells, and fluid inside that. And the cells act like a little barrier around the egg. What you could argue is the most important cell in the body, and they protect it, they feed it, and they make steroid hormones that are very important for the cycle and for your well-being. Now, in a polycystic ovary, all of that's exactly the same. You've still got all these eggs in the outside of your ovary. They still get into these little follicles. The only difference is that you've got more of them. So I've drawn a little cartoon here. So when you have a scan, if you've got a normal ovary, you can see, oops, difficult to do it as a mirror. You can see one or two of these little, what look like black holes because the fluid absorbs the sound waves in an ultrasound scan. If you have a polycystic ovary, you may have seen something that looks like this. So the follicles, again, they're in the outside edge of the ovary, but inside the ovary, not on the outside. And we know they are follicles, they still have eggs inside them. They're generally healthy structures, and they're not, strictly speaking, cysts. So forget that you have cysts all over your ovaries. You don't. You just have more follicles inside the ovary. So why are these little follicles a problem? Well, one of the reasons is that they carry on making hormones the way they would as if they was in a normal ovary. It's just that there's more of them. So seeing as it's European Hormone Day, any excuse for a party, right? Let's say we'll start with what is a hormone? So a hormone is just a chemical messenger, quite tiny, and it's released in one part of the body. It travels around in the bloodstream and it has an effect in a different part of the body. Now, in order for it to hit and have an effect on something that's in a different part of the body, that cell has to have on the surface of it something called a little receptor. So let's think of that receptor like a door knocker. So hormone comes from, let's say, the gland in your brain, goes around in your bloodstream, hits the ovary, gets hold of the door knocker and goes bang, bang, bang. And the cell then knows that the hormone has been released and it has an effect on whatever, let's say the cell in the ovary. So that's how hormones work. In turn, the ovary makes a whole raft of hormones, two really important ones. They go back up in the bloodstream to the pituitary gland in the brain and tell it what the ovary is up to. And so through the menstrual cycle, the pituitary and the ovary release hormones in a coordinated way, telling each other what's going on. Now, there's another hormone, which is a bit pesky in PCO, but it's made by the normal ovary as well. In fact, you can't make any of the female hormones without it, and that is the male hormone testosterone. It's quite a few male hormones. If you've had a blood test, they may have measured several of them, but really the most important one, and the one we'll talk about today, is testosterone. So classically, a male hormone, but as I say, all women have it. In women with normal ovaries, the levels are about a half up to about one and a half. 1.5 what? The units that they use to measure it, in the UK at least, are nanomoles per litre. I don't worry too much about what that is. So it's half to 1.5 nanomoles per litre of blood. What's a nanomole? So nano means 1/1000th. So the amount of testosterone that's circulating is in the levels of 1/1000th. It's incredible. And if you've got polycystic ovaries, you might have 2/1000th. So it's just very slightly higher. So it goes whizzing round in the bloodstream and it's going to hit, let's say in a woman, your skin. So it's banging on the door knocker of the skin. Obviously, if you've got twice as much banging on the door knocker, it's going to have that effect on the skin. The levels are still minute, but women's skin is super sensitive to testosterone. And what it does is it stimulates the growth of hair follicles, so you might get hirsutism, and it stimulates the little glands in the skin to make more oil or sebum, and that causes acne. If you're very unfortunate, you may get both hirsutism and acne, and it's consistently described, not surprisingly, as one of the most distressing symptoms of polycystic ovary syndrome. We can talk a little bit at the end if you're interested, if you have this problem, about some of the treatments, but I'm going to move on a bit from talking about the possible treatments of PCO because we've got quite a lot to cover. So if you have polycystic ovaries or polycystic ovary syndrome, What's the difference? If you have the syndrome, it just means you have polycystic ovaries on a scan plus one or more of the symptoms. And that might be hirsutism or acne, or more likely it might be an irregular cycle, or you might have both of those. You need to have really 2 out of the 3. So you can have problems with your skin or raised testosterone and an irregular cycle, but not actually be shown to have PCO on a scan. You've still got polycystic ovary syndrome. I often hear people say, "Oh, I have an irregular cycle. I'm really struggling with my skin. But when I had a scan, they said my ovaries are not polycystic." I bet you if you had a scan 2 months later, they would be polycystic. So scanning is an art form, and the ovaries are very plastic. So cysts come, cysts go. If you've had a couple of regular cycles, they might look a bit less polycystic. If you've not had a cycle for ages, they're much more likely to look like our polycystic ovary here. So if you're told you don't have polycystic ovaries, don't believe it. And I know that's easy for me to say, and it does mean you've got to fight with your clinician, but really, you've got PCO, frankly. Almost everybody with hirsutism and or acne and or irregular cycle has got polycystic ovary syndrome. Okay, so what else are the problems that testosterone might cause? We do often hear women who suffer from male pattern hair loss. So whereas testosterone stimulates hair growth on your face, it actually causes hair loss on your scalp. And again, for many women, that can be quite distressing. And your aim really for both is to minimize the impact of testosterone on your skin. See a question has here popped up about can we do hirsutism treatment? Let's see if we can have a bit of time at the end. But I think that really is a separate session because it's complicated, and I think we need to go through it quite slowly. It's quite important, and there are a lot of different things available. So can we flag up a hirsutism session later? Sorry if that's what you're dying to hear about, but
We're also going to have a dedicated webinar with a consultant dermatologist in May as well, just to focus purely on excess hair, acne, and hair loss as well.
brilliant. Okay. So we've talked about testosterone. Now, the other thing that you may hear when you're told you've got PCO, or the first thing that pops up if you go off and Google it, which of course we all do, is that it's causing a hormone imbalance. What do we mean by a hormone imbalance? I think in PCO, really, there are several hormone systems that are out of balance. So the first thing I talked about was how the pituitary gland, which is a little gland just behind your eyes here below your brain, controls the ovaries, and how the ovaries feed back and tell the pituitary what's happening. During a normal menstrual cycle, the hormones from the ovary and the pituitary go up and down, actually really like a yo-yo through the cycle. There are 4 main hormones that are going up and down, 2 from the pituitary, 2 from the ovaries. Each rise or fall is dependent on the one before it. And in a regular ovulatory cycle, everything happens in a coordinated way, and they go up and down in turn. Once you start to reach a point where you're not ovulating regularly, that balance of hormones and the messages going backwards and forwards soon get out of kilter. And that really is the first hormone imbalance. So there's an imbalance in the way the ovary is telling the pituitary what's happening, and therefore, in turn, the way the pituitary is trying to drive the ovary to grow a follicle and to ovulate. Now, how do you get that back into balance? Not easy. Definitely weight plays a problem, and I'm sure you, as a woman with PCO, you get this message all the time. I'm going to talk a little bit about weight. I don't believe in diets. You'll be pleased to hear they don't work in PCO. So how to get that back into balance depends really on what you're trying to achieve. If you do have infertility, the first kinds of medical treatments you'll be offered are all aimed at correcting that particular hormone imbalance. So it's about getting the messages back to the pituitary in a way that allows the pituitary then to drive the ovary. So either by stopping the messages altogether from the ovary so the pituitary can get its act together and not be confused, or by shutting the messages off in a different way and again allowing the pituitary to reset itself. And those are the drugs like Clomid or clomiphene, or the ones ending in Zol, which are the ones, again, that shut the messages off. And again, there's going to be a separate session about treatment of infertility per se in PCO. So the other main hormone imbalance, oh no, let me just mention, while I've talked about hormones coming from the ovary, two of the hormones that come from the ovary are quite powerful steroids. One is estrogen, which I'm sure you've heard of, and the other one is progesterone. Estrogen you tend to make in the first half of the cycle, which is why when you are growing a follicle, and progesterone is a hormone that you make in the second half of the cycle after you've ovulated. Now, if your cycle is a little bit out of sync, or you're ovulating irregularly, or you're trying to grow a follicle and it takes you longer, then the cycle of steroids that your body is used to having or should be having are again out of kilter. And if you add to that a little bit more of the steroid testosterone, you can see why you may be more likely to have swings in your mood. Estrogen is a feel-good hormone. If you're not getting the right levels of estrogen at the right time, we know that that can cause feelings of depression, of anxiety. People who've had no estrogen for a while, who suddenly go onto estrogen, often report that their mood is better, so things like HRT. So it does make sense, really, if your hormones are imbalanced, that could contribute to feelings of depression, mood swings, and something else that contributes to that, which I'm going to go on and talk about in a minute, is also the balance between glucose and insulin. Again, swinging around, often changing the way you feel. I think also if you look at polycystic ovary syndrome altogether, it's a syndrome where you may struggle with your skin, something you face the world with every single day, something that makes you gain weight, something again you can't hide, it's something you're fighting every day, and something that may alter your chances of having fertility. It's not surprising, is it really, that this could get you down? Of course it is. It's probably three things you would least want to have as a woman. So no big, it's not going to take Einstein, is it, to realize that polycystic ovary syndrome is likely to affect your mood. Okay, so I mentioned, I don't know if you want to stop, Rachel, and pick up anything.
Yeah, we have a couple of questions, particularly around the relationship between hormones and food, and whether they then hormones and food and exercise potentially more effective during certain times of the month when your hormones are, doing different things. I'll let you go with that one, and then I'll grab another one.
Okay, I think to put that into context, let me talk a little about insulin and glucose, because I think exercise is an absolutely key factor in controlling polycystic ovary syndrome. But it's no use if you just say to someone who go away and exercise. I think you really need to understand why, what it's doing, and how it works. And so I'm going to talk a little bit about insulin resistance, glucose, and insulin in PCO, and why it goes a bit haywire, and how exercise can help you correct some of that problem. So, insulin, again, a hormone, a very powerful hormone, and one that is out of balance with glucose in polycystic ovary syndrome, and possibly actually the most important hormone imbalance that you're going to suffer from. Not everyone with PCO has a problem with insulin, but the vast majority of women do.
Is that the
So,
case even for the thing that we get, I guess we see time and again, is even if you are slim with PCOS, do you still have the insulin imbalance, or is it just with those that are overweight?
a lot of women who are slim with PCO won't have the problems with insulin, but it's just sitting there waiting for them to put on a few pounds, and then it manifests itself very quickly. It starts much earlier with weight gain than it would in someone with normal ovaries. So women with who gain a few pounds with normal ovaries won't switch into having insulin problems. Where if you've got polycystic ovary syndrome, you do. The other people who are much more likely to get it when they're slimmer are women from the Asian subcontinent. So women of Indian and Pakistani heritage. We know there's a lot of diabetes in that population and a lot of polycystic ovary syndrome, and the two tend to run together in families. So even very slim women with polycystic ovary syndrome who are of Indian subcontinent heritage will find they have these problems much earlier, and even without gaining any weight, unfortunately. So, insulin is a hormone absolutely vital, made by the pancreas, and it's going to go around in your bloodstream and control the way that glucose is taken out of the bloodstream into the cells, and in particular into the muscles, where it allows the muscles actually to work. So when you eat a meal, it's broken down very quickly, gets into the bowel, and the glucose in your food is released into the bloodstream. And in response, insulin goes up in the bloodstream and allows the muscle or cells, particularly the brain actually, to take the glucose up. So think about the door knocker analogy again. So here's your muscle, down comes insulin in response to glucose, knock, knock, knock on the muscle cell. A little channel opens and the glucose goes through the channel into the muscle. Once the glucose level drops in your blood, insulin drops, and it all stays quite nicely low until you have another intake of glucose. Now, if you have polycystic ovaries or polycystic ovary syndrome, what happens is that message on the muscle is muffled. So it's like someone wrapping a cloth around the little door knocker. When the insulin comes along and bangs on it, the muscle cell doesn't hear it. So insulin has to get much higher in the bloodstream for it to knock on the muscle to allow those little gaps to open and the glucose to go in. So your insulin level starts to drift up. Now, while you're young and healthy and you're not been doing this for very long, your insulin can cope. So your pancreas will just put out more insulin, and that allows you to keep the glucose down in the level where it's meant to be. So this is not diabetes. This is insulin resistance. So your cells are resistant to hearing that message from the insulin. Now, why is that a problem? It's a problem because insulin causes all kinds of problems in your body if you've got polycystic ovary syndrome. The first thing it does is make the little cells in the ovary make more male hormone. Those little cells around the eggs absolutely love insulin, and they chomp it up, and in response, they spit out a lot more of the male hormone, and that goes off into your bloodstream and can hit the skin. You know, you hear people sometimes say, every time I eat a chocolate, I get a spot. Well, yes, I'm afraid it's probably true, because the chocolate instantly converted into glucose drives your insulin much higher. Insulin drives testosterone. Testosterone hits your skin. Out comes a spot. I mean, it's not quite that simplistic, but yes, is there a relationship between eating sugary foods and having your skin go worse? Yes, there is. The other thing we know insulin does is it affects the amount of testosterone that can hit your skin. This is a bit complicated, so I've made a little cartoon. What you may have realized if you've gone and had a testosterone measurement is that they've measured another hormone, and this is something called a binding globulin. It goes by a really complicated name, but I've written it out. It's called sex hormone binding globulin. Doesn't exactly roll off the tongue, does it? Or SHBG for short. Now, why are we bothering about SHBG? Well, it's because it's really important. So here's a little cartoon, showing skin. Here's a little receptor for testosterone, and that fits neatly in the receptor and causes the skin to make more of the male hormone, to grow the hair or make more sebum. Now, the wonderful thing about SHBG is it fits onto the testosterone right at the point where it can interact with the skin, and it stops it interacting with the skin. So it's a binding globulin. It mops up the testosterone and stops it hitting the skin. So when you had your testosterone measurement, they would have measured the amount of SHBG, and they can look at how much testosterone is free to interact with the skin and how much is bound and therefore cannot interact with the skin. And the reason this is important is because almost all testosterone is bound and only a little bit is free. Insulin reduces the amount of SHBG that you make. So that means more of the testosterone is free and can act on the skin. So anything you can do to reduce insulin allows you to make more of your own SHBG to mop up that testosterone and stop it having an effect on the skin. It is a bit complicated, I know, but because only 1% is free, any tiny change in SHBG can increase that quite dramatically and therefore have an impact on your skin. So how are you going to drive up your own SHBG? You can't take it, unfortunately. You have to make it yourself. The way to do that is to get your insulin level down. And I'm going to focus now a little bit on how to do that. Don't know if there's any other questions that have popped up, Rachel, that you think.
Yes, there are, but my mind just went that obviously, as you know, been part of Verity for a very, very long time, that is the best understanding I have ever had of SHBG and how that interacts with insulin. Thank you.
I
I'm
mean,
sure
it's not complicated,
it
really.
just doesn't get explained
No,
to us in
and
ways that we can understand.
exactly, or how important it is. It kind of gets forgotten about. The doctor will almost certainly have measured it, but they don't spend time explaining to you what the difference between free and bound testosterone is, why that's important, and how you yourself can get your SHBG up. Probably because they don't actually really understand it themselves, or they
Yeah.
don't have time, they just don't have time.
So we
So,
do have
yeah,
quite a few
yeah, go
questions
on.
that have come in. So I'm going to try and group them together because it's such a big topic and we're already halfway through. It's gone very quickly.
Oh, okay,
Um,
sorry.
no, please don't. It's been amazing already. So some of the questions we have are, can cortisol produced during exercise have a negative effect on symptoms? And are there any
No.
steps we can take before exercise to keep insulin levels needed lower? So I'll give you those two and then I will
Okay, cortisol. There's been quite a lot of work on cortisol and PCO. In fact, we've done quite a bit of it in my own lab. There are some small differences, but nothing really that explains why you get PCO or you know to prove that stress makes it worse. I think it makes your ability to handle the symptoms worse. Of course it does, but that's the same for anything, whether that's pain or arthritis or whatever. So don't get bound up with cortisol. Not no is the answer.
okay.
Can you do more for your glucose and insulin before you exercise?
Yeah.
Not really. We're going to talk now a little bit about minimizing your insulin. Insulin really is the enemy in PCO, and associated with that is glucose, because glucose is what drives up your insulin pretty much single-handedly. And by glucose, we really mean sugar.
So we have two questions that I'll just throw to you
Yeah,
before you go into that because you're probably
okay.
so. So one is so when testosterone levels are measured, is it more important then to understand your free versus bound measurement versus what your actual level is, which is typically what you'll get told?
Exactly. Well done. Yep. Yeah.
Gold
It's
star for you
important to
who answered
know
that
the
answer to that question.
it's important to know the overall level, just because you want to be absolutely sure that there's nothing else going on, particularly
Mm,
in somebody who has a sudden onset of hirsutism. You want to check that that testosterone is definitely coming from the ovary and it's just coming from the follicles, because there
mm,
can be one or two other things that make testosterone that you need to rule out. But
mm.
yes, have a look at your free versus bound. It might be really quite illuminating, actually.
I want to race out to get mine measured now.
Yeah.
So if you don't have problems with your skin or an androgen related symptom like so the hair and the acne, does this mean then that you have enough SHBG, and can we conclude then that insulin isn't one of your effects in PCOS?
Unfortunately, not. Although there is a relationship between the amount of testosterone and what happens on your skin, for some women, there's no relationship at all. So you could be told, you could go to the doctor, you've got quite bad hirsutism and acne, and they say, oh no, your testosterone's not high. That's irrelevant. You've still got hirsutism and acne. Doesn't mean you don't need treatment. You've got it. It just means it's not linked to a really high testosterone. Doesn't mean you don't need to get your testosterone lower. You do. So it, insulin is an underlying problem in almost everybody with PCO. And if you don't have problems now, it's because you stayed slim, probably. As soon as you put weight on, it's likely to be more of an issue.
Yeah. We are understandably now getting into the metformin related
Yeah,
questions.
I'll come on to metformin in a minute.
Okay, perfect. And also pill and controlling that. Um, And there's another last one. Whenever I eat sugar, I start feeling shaky and sweaty an hour or so later. Blood tests show I'm not diabetic. Is this insulin resistance?
Yes. So it's the fact that your glucose is not easily controlled by your insulin. Your glucose is going up, but the insulin isn't going up at the same rate. So I can't, I'm sorry, because I'm doing it as a mirror image here, so I'm struggling. So what happens is your insulin has to go up much higher to get the glucose down. It tends to overshoot, doesn't come down fast enough. So what happens is your glucose then plummets. And that's when you feel a bit nauseous, a bit shaky. What you have to do is, if you want to have sugary things, eat small amounts more regularly. But really, sugar is the enemy, I'm afraid. It is for everybody. You know, it sneaks into almost everything you eat. If you actually start looking at the amount of sugar on your packets, you'll find it's in bread, it's in pasta sauces, it's in almost every processed meal. It tastes good. That's why they put it in, and it's cheap. It's one of the cheapest things there is. So they'll bulk up almost everything they can with sugar. It's a very cheap ingredient. But sugar's in everything. So people drink fruit juice. You have a glass of fruit juice, you think it's quite healthy. If someone said to you, put 4 spoons of sugar in your tea, you would say, are you kidding? But you had 4 spoons of sugar when you drank that glass of fruit juice. You've got to be careful and watch these things. Some of the milk alternatives also have quite high levels of sugar. Try and go for a sugar-free one if you can. So you've got to really try and get down your insulin. Several ways to do that. The first one, which we've just said about, is sugar in your diet. I'm not saying go sugar-free. You're going to feel rubbish, frankly. I've tried it because I am pre-diabetic. First of all, I lost weight like Billy-O and couldn't gain it. Secondly, I just felt rubbish the whole time. So I just now, I don't eat sugary cereals. I don't eat chocolate bars. Actually, that's not true. Yes, I do. I just watch when I eat them. So when are we going to think about the glucose and insulin the most? The most important time to think about insulin and glucose is in the evenings. Most of us are eating too late, and also we are eating our snacks after dinner. And that's been shown for everybody pretty much. So what happens? Up goes your glucose after your dinner, up goes your insulin. You go to bed on a full stomach. You're not using your muscles at all during the night, pretty much. And your insulin and glucose are going to be up for most of the night. It's a disaster for PCO. So if you can eat, yeah, me too. If you can eat dinner a little bit earlier, even a little bit earlier, or, and I know this isn't realistic, but it's ideal, have a walk around the block before you go to bed. It's going to drop that insulin in your bloodstream before you go to sleep. It's going to stay down all night long. Every night, your glucose and insulin will be up if you eat before you go to bed. Even worse, if you eat a bar of chocolate before you go to bed, or any sugary snack or drink, or I'm afraid, glass of wine, bottle of beer, late in the evening, it's a disaster because your insulin, again, is going to be up for a long, long time because there won't be any muscle activity in the night to try and get that glucose down. So think about what you're eating late at night more than any other time. If you can, try and eat earlier. I know it's not easy for most of us, but try not to have a dessert after your dinner. Try not to have a sugary snack. If you want to have something like that, think carefully about what you're having. I know it's not so much fun, but carrot sticks and hummus, ideal. Boiled eggs, actually, fabulous. You can even slather them in mayo because it's not going to put your glucose up very much. Anything you can eat that's not sugary after your dinner, if you really want a snack, have a good think about it. Have a look at those protein bars. I bet you they're about 40% sugar. Most of them are. It's really depressing. Yeah. But just be aware. I mean, you're not going to suddenly change what you're eating overnight. So let's come on to talking about diet. You know, you might have been told to go away and do low glycemic index, brown rice, you know, eating something that looks like potting compost and having big plate full of vegetables and everything boring. It's not going to work, is it? We know it doesn't work. I don't tell anybody ever to do that. I think the best way to control your weight, and particularly to control those swings in insulin and glucose, is to think carefully about sugary stuff, but mainly to slightly reduce your portion sizes. So carry on eating what you normally have, try and avoid sugar, but cut down your portion size. If you can have about 10% less on your plate, and that's manageable, I think, it's been shown that will allow you to lose about 250 grams a month. Now, that doesn't sound like much. Within a year, that's 6 kilos. So it's manageable. Anything that allows you to lose weight fast, whether that's a crash diet, liquid diet, cabbage diet, beans, you know, a bean diet, because I see that now as well, you are going to put that weight back. We all know it. Weight Watchers, success rate, long term, 1%. Frankly, I think it's a ripoff. It doesn't work. The only way to lose weight long term is very slowly doing something that you find manageable. And I think 10% portion size reduction is manageable for most people. You're not going to feel particularly hungry and you can keep that weight off. So, other tricks. It takes 20 minutes for your brain to realize that you've eaten. I don't know about you, but I eat my dinner faster than 20 minutes. So, a little snack before dinner. While you're making your dinner, have a few carrot sticks and hummus, have half a boiled egg, again, put mayo on it. Anything you fancy, a few apple slices, handful of almonds, 20 minutes before your dinner. So that message has already started to get to your brain before you even start eating. So you should start to feel fuller sooner. And you won't get to the end of your dinner and think, oh, now what's left in the fridge? Oh, there's a few potatoes left. Okay, I'll have those. The other trick, have a glass of water with your dinner. Again, that pushes the stomach out, sends a receptor message up to the brain that you've had a meal and makes you feel fuller faster. Or a low calorie drink, not a sugary one. Try not to have too much in the way of sweeteners, but water's the best, but again, a bit boring. So a couple of tricks for you to try there. The pre-dinner loading, and that's not loading with vodka. Lots of calories in vodka, I'm afraid. Although vodka
Yeah.
and slimline, much better than a glass of wine. So the other things you can do to get your insulin down, exercise. In fact, exercise almost better than weight loss. What kind of exercise? Has to be building muscle. So that means resistance exercise. So repetitive lifting, pushing in the gym with your legs against something, or cycling. Walking's not great. If you do enough of it, yes, but very few of us have the time to do enough. To burn off chip shop fish, chips, and peas, you've got to walk for 9 hours. horrendous, isn't it? Yeah. So walking's great. It is good cardio, but it's not going to let you build up much muscle, and it certainly doesn't burn calories very much.
The muscle is important for dealing with the insulin when
Taking the
that knocker.
glucose, yeah. So even if you can build your muscle up by 5%, even while you're fast asleep, that muscle is needing glucose. So it's going to take glucose out of your bloodstream even when it's not working. Idle muscle still uses glucose.
Had a penny drop moment.
Yes. So,
Then,
and
okay.
what's been shown in PCO is that women have less muscles in their legs. I don't know why, and I don't think we know why. So if you can get those leg muscles built up, again, resistance training is the best. So stepper, cycling, pushing, or swimming is good too. That builds up the muscle. Down goes the glucose, down goes the insulin.
And up goes the SBHG.
SHBG.
SHBG. Right.
Yeah.
So it's almost like you're tackling it from two angles. You're
This is holistic healthcare. No medicine. You're hitting it from every angle, and it can work quite quickly. Actually, if you can build a bit of muscle, you will find your glucose goes down quite quickly, and your insulin will start to balance itself. You can build enough muscle to get your cycle back without losing weight.
I think that is such an important message because we've talked about it, you and I, but we hear over and over again is go away and lose weight, lose weight, lose weight, your BMI, your BMI. And the focus is never on muscle. It's always on weight. You feel demonized. You face weight stigma when, in healthcare settings. And instead of having that explained about, the SHBG, the insulin and the muscle and the importance of building that muscle, taken away from the weight, it makes you, well, that's something I can do. That feels achievable. Whereas I know the weight loss, I've tried and tried and tried. And so I think that's a really practical and inspiring bit of advice.
The
Um,
other, I should put a little caveat. Of course,
yeah.
muscle's heavy.
Yeah. So you might go up. Your weight
Yes,
might
your
go up.
weight might go up, and you might think, "Oh my God, this is a disaster."
Ellen told us to.
There should be, if you're in a decent gym, there should be something that looks at your muscle to your lean mass to fat ratio on a machine. The
So
other
I
thing
have
you
some
can
questions
do,
specifically about legs. Is
we
it a
don't
focus
know
on legs
why, yes, but leg
because they don't have
muscles,
as much muscle, or they burn more, they consume more glucose than other muscles, or
yes, they're big muscles. They're really big muscles.
right.
But and for some reason, women with PCO don't seem to have the strength in the legs that other women have. And I don't understand why, frankly, particularly if you're carrying a bit more weight around, you'd think you would, wouldn't you? Because, it's not, if you're carrying a few extra kilos, you
Yeah.
imagine having to carry a few bags of flour around all day. It's not insignificant.
As someone that has lost a significant amount of weight, just the difference in, I was like, oh, this is actually not so, like, it's easy. Things are easier, and it is a cliche, but it's true. It's like you are carrying, a lot around, but you don't notice it when you're doing it so much. But so we've got a couple of
So shall we jump onto metformin quickly? Because I know, or is there something before that?
it's related. There's a couple of questions then around complex carbohydrates in the evening or reducing carbohydrates. That carbohydrate comes up quite a lot.
Yeah, I mean, carbohydrate is the enemy, isn't it? No, not really. Ideally, yes. Would you eat complex carbohydrates in low amounts, with the brown rice? You might, but are you going to stick with it? Don't do anything that makes you miserable. I hate brown rice, frankly, and I'll have a bit of it.
Yeah.
And I would just say, eat a bit less. It doesn't have to be drastic, and drastic doesn't work. If there was a simple diet that women with PCO could stick to, we'd all be doing it. Nobody would be diabetic. We know it doesn't work. And I think one of the main problems with PCO is there's no guidance about diet. People who are talking about diet are unrealistic. And also, they don't know the tricks. You know, there are these tricks. And if you understand your body and you know what you're doing, I think you have a much better chance of taking control, frankly. There
Mm.
will be times when you're absolutely desperate for some glucose, for some sugar. You know, just go easy on it. Only eat half a Kit Kat. Don't eat the whole thing. Eat it slowly. Enjoy it. I sat next to a woman the other day eating a packet of custard creams. She was on her phone. She ate the whole packet while I sat next to her. I don't think she even realized she'd eaten them. When she reached for the last one, she was surprised it wasn't there. You know,
I have been guilty, yeah, very
if
much.
you're going to enjoy something sweet, savor it, eat it slowly. Just try not to eat it late in the evening. I
Okay.
would say,
Sorry, I just have a clarifying question, which was when we asked about complex carbohydrate, like potatoes, not to lose weight, but actually as dinner to avoid sugar and snacks and things. Does that help you?
yes, it will. Actually, the thing that stops you feeling hungry is protein. And that's really been shown massively. So, protein isn't going to break down into sugars quickly. So, if you can increase the amount of protein on your plate and reduce the carbs in proportion, yes, okay, sweet potatoes better than normal potatoes. But I just think, do what's realistic. I don't think if you make massive changes in your diet, you'll stick to it. I mean, we know we don't. I have all these good resolutions, frankly, my dear. It's only because I measure my glucose in the morning sometimes and get the shock of my life. And I'm really quite skinny, but I'm on the edge of being underweight. And I've still got insulin resistance. So it's hereditary with me. So I'm supposed to not have any sugar, but life's not like that.
Life's also for enjoying.
It is. And if you're miserable, guess what? You're going to go off and eat something that you like that's, you know, just keep an eye on sugar on labels because it is sneaked into everything.
Just before we move to metformin, which I know we'll definitely have some interest in, conscious as well of the time, but we did have someone saying that they are a sugar-free eater. They do swimming, they do resistance at the gym 3 days a week, yoga a couple of times a week, and they have lost 2 stone already, which is
Ooh.
incredible. So well done to them. But they do still need to take Provera to trigger bleeding. Is there anything else that she can do?
Oh, I mean, I would need to know a bit more about her history and everything. It's very hard to advise someone one to one. It depends also how much more weight they think they've got to lose. I mean, fantastic job for losing that, honestly. And if you can work out your BMI, you're aiming to get your BMI down to 21, ideally to get your cycles back. Um, I mean, there's a whole story here we need to touch on at some point in the future about not having cycles and the risks that that has for your
Mm.
womb as well, actually.
Have a question earlier on around
Yeah, uterine
increased risk
cancer.
yeah.
Yeah.
Whereas I think it's endometrial cancer rather than uterine cancer is the risk. But yeah,
Yeah, I just bung it all together because,
yeah.
yeah,
All at
okay,
the same
yeah,
time.
yeah.
Right, so we've got conscious we've got 5 minutes left in our
Let's
time.
go to metformin. Yeah,
So go to
we can
metformin
pick up again on some of these points and do them. I think we could probably do this all over again because there'll be a lot more questions. Yeah. So I talked about different ways to get your insulin down, and that was actually, avoiding sugar, doing a diet, not having stuff late at night, exercising, the most important. And of course, the third one is to take some kind of medication that helps you with the insulin and glucose. So, how does metformin work? Well, it stops your liver releasing glucose because you store a lot of glucose in your liver. Metformin stops that coming out or helps it. It stops you taking glucose out of your bowel So it reduces the amount of glucose that can get out of your food into your body. But the other thing it does, more importantly, is it amplifies that door knocker. So it makes the knocker louder, the little gates open up more, and more glucose goes into the cells. There is another way it works, and that is, particularly when you first start taking it, makes you feel a bit nauseous. So you tend to avoid fatty foods. You might not fancy things that are a bit more nausea-inducing. Guess what? You lose a bit of weight. Down comes your insulin. And we think one of the mechanisms of action of metformin actually is weight loss due to the fact it gives you a bit of nausea when you first start it. Not great. There are better ways to give yourself nausea. Now, is metformin a good drug for PCO? Probably yes. If you've tried everything else and you're already heading towards insulin resistance or glucose intolerance, which is getting towards diabetes, probably no harm in taking metformin. For most people, there's no serious side effects. It may help you keep the weight down, therefore reduce the insulin. The lower your insulin, the better your skin will be, and the more likely you are to ovulate. We know as your insulin goes up, the number of cycles you have per year reduces. There's a direct relationship. So is metformin bad for you? Probably not, actually. And is it good for you? Absolutely. Fantastic studies have been done looking at cancer of all kinds in people who take metformin, and it reduces many, many types of cancer by about 25%. So that's massive. You could almost say, let's put the whole population on it and reduce cancers by 25%. But if you're not diabetic, it actually will make you feel quite unwell. So it's not a drug you should take if you're not diabetic. So I don't have any issues with metformin. I think it's worth trying. Getting a GP to prescribe it might be more of an issue, but again, that's something we could talk about. How to handle your GP might be a whole session for the future.
It is. We recently had a primary care and secondary care webinar,
Oh, of
and
course, with
the
Judith.
whole,
Yeah.
and it's a whole topic is how to best work with your GP. We've probably got time for one last question before we wrap up. I have also put a poll on the webinar for people just to please leave your feedback so that we know what you enjoyed, what you learned from today, and also what you would like to see coming up. Apologies to everyone that we couldn't possibly get to all the questions. I knew that we would be inundated.
Maybe we can have one where we do nothing but questions.
Yes, absolutely. That will definitely go down well. So I think we'll end lastly on around is insulin resistance assumed because of I'm going to murder the pronunciation of this. You can probably help me, Helen.
Hyperglycemia.
I
can't see it.
Oligomenorrhea.
Amenorrhea?
Oligomenorrhea.
Oh, oligomenorrhea. So oligomenorrhea is just a posh name for irregular cycles.
Right. Okay. They're just trying
to... not really. No. The insulin resistance in most women with PCO comes with weight gain, unless you have a very strong family history of diabetes, in which case you may well have it at a normal weight, like me.
Right. Thank you. We would, yeah, the questions are still coming in, and I'm really sorry.
Oh, I'm sorry, folks. Yeah, I know.
But if you don't mind, Helen, we would love to have you back just to do a quick Q&A session, and I think that we'll just always get lots. So please, if you are interested, make sure you stay tuned to Verity's social media channels and we can let you know when those are. Please do take a minute before you leave the webinar today to drop your feedback into the poll that should have popped up on your screen. And Professor Helen Mason, as always, thank you so much for giving up your time, for your lovely diagrams, for your incredible patient-friendly and empathetic explanations. I feel despite having, been involved with Verity now for almost 2 decades, that I learnt more today than I have in a very long time. So thank you, thank you, thank you so much. And yeah, we appreciate you and your time and your empathy for people with PCOS.
So for everyone out there, don't give up. Keep with us for your PCO journey. I'm sure we can help you feel better and manage the symptoms and understand what the heck is going on in your body.
Great. Thank you so much.
Bye to everyone.
Bye.